So thank you, Giancarlo, for this nice introduction, and thank you for the organizing committee for inviting me in this fantastic city of Roma. So what I want to share with you in a couple of slides is all the possibilities of the prevention of preterm birth with progesterone, and I have to thank Yves, our previous speaker, who will really facilitate my task, because he was showing how important is the cervical length, and I will show you that probably based on this important risk factor, we have some good data to support the efficiency of vaginal progesterone in the prevention of preterm birth in women with a short cervix. So I try to have my next slide. Okay, so that's my conflict of interest. I will not go in detail in this complicated cartoon because I think that Yves did it fantastically. But what I want to show you is the key players as a risk factors for prematurity. And you don't have to be a big scientist to see that delivery has something to do with inflammation, and inflammation is probably induced by the production just before the onset of labor of prostaglandin, the PGE2-1, which is the most important one. And you will see that along the pregnancy, progesterone is protecting the woman against the early production of those prostaglandins, who will create an inflammatory environment around the cervix. And as Yves was nicely showing, the inflammation of the cervix leading to a shortening of the cervix and a softening of the cervix will be the key problem on the prematurity. And we have now, you will see, nice data to suggest that progesterone, which is a very potent physiological anti-inflammatory hormone, can really prevent this early inflammation of the cervix. So to keep it simple, progesterone, we all know, inhibits the inflammatory responses associated with preterm parturition. And also, we know that progesterone doesn't work only in one pathway, but progesterone also is very active in promoting myometrial relaxation. So to convince you about those mechanisms of action, which are very important because the biological plausibility is very important to believe in the clinical trials, and certainly when it's so difficult to anticipate the women who are really at risk for a preterm birth, we have to know and to understand how progesterone works in the prevention of preterm birth. So in this cartoon, it was suggested by the group of cartoonists about 10 years ago. You can see how important is the crosstalk between the membrane and the nuclear receptor. So the key message is to show you that there is a huge difference in how progesterone protects the whole pregnancy against the risk of a premature delivery in the early stages of pregnancy, because progesterone works and crosstalk with the receptors, the classical pathway, and leading to a binding to the progesterone B receptor. But just before the onset of labor, you have a change in the hormonal environment, and certainly at the tissue level, at the myometrial level, and some estrogens, and more particularly estriol, but also estradiol, is increasing at the cervix level and giving a kind of decrease in the influence of progesterone, and that will be the real first hormonal signal, at least, for the onset of labor, because your progesterone, instead of binding directly the progesterone B receptor, will crosstalk with some membrane receptors, which are binded with G proteins, who can give and provoke the opposite effect of progesterone. So instead of keeping the endometrial at a relaxation level, due to this activation of the membrane receptors, it will be an inhibitory effect on this relaxation process, leading to the onset of labor and to the onset of contraction. And that's all possible because you have a shift in your progesterone isoform receptors, and that because this crosstalk between progesterone and the membrane receptor, you have a shift from the progesterone B to the progesterone A receptor. And the progesterone A receptor will induce exactly the opposite effect of the progesterone in the early stage of pregnancy. So there was some theoretical model suggested by the group of Messiano in GCM 2002, so long times ago, which was modeling the role of the myometrial estrogen receptors and the progesterone systems receptor in the regulation of the human pregnancy and the parturition. And to keep it simple, you can see that as long as progesterone is stimulating your progesterone B receptor, you have a relaxing effect at the myometrial cell level. But once the estrogen take the leadership, they activate the isoform of the progesterone B receptor in progesterone A receptor, and together, binding the estradiol receptor at the myometrial cell, you will have a shift from a relaxation pattern to a contraction pattern who will induce the contraction. That was the theoretical model put in place by Messiano a long time ago. And we understand now how it works because we know that it has to go through the opening of gap junction. As long as the gap junctions are closed, there is no communication in between the myometrial cells, and there is no synchronous contraction possible, no onset of labor, as long as those connections are closed. And you can measure that based on some proteins, the connexin 26, for example, which is maintain a very high level during the whole pregnancy, but it will decrease just before the onset of labor, which is a signal of the opening of the gap junction and a clear communication from one myometrial cell to the other. And you can measure that also with the increase of the production of connexin 43, which remain very low during the whole pregnancy, while when the uterus stay quiescent, but will increase immediately before the onset of labor. So we understand that progesterone has a lot of different pathways to keep this uterus very quiet. It works on the nitric oxide synthetases. It inhibits the formation of gap junction. And we also that not only natural progesterone, and that's probably a key message from my presentation, but also the natural metabolites of progesterone are inducing a uterine quiescence through interaction between the nuclear and the membrane receptor. So not only the mother molecule, which is progesterone, but also the metabolites are playing an important role. And progesterone will for sure maintain low level of prostaglandins, oxytocin receptors, and will block the intracellular calcium channel, making any onset of labor very difficult, just if you look at the hormonal environment. So in this nice cartoon in the New England Journal 2011, you can see that progesterone plays a key role, not only just before the onset of labor, just for the prevention of preterm birth, but it plays a key role during the whole pregnancy maintenance, because keeping your progesterone at the tissue level at a high level, it inhibits the microRNA messenger who are responsible for producing the opening of the gap junction and the production of oxytocin receptors. So as long as you can keep your progesterone as high as possible during the whole pregnancy, there is no possibility for production of oxytocin receptors. But when you have this progesterone withdrawal, as it was explained before, you can see that you don't inhibit anymore those transcription proteins, and then your microRNA can deliver the message inducing the production of connexin 43, opening the gap junction, and leading to the production of oxytocin receptor. And the key message from this publication is to show that once this process is ongoing, it's not possible to stop the process anymore, even with very potent tocolytic drugs, and certainly not with progesterone. So coming back to the presentation by Yves, it makes sense, and based on the biological plausibility, we can we know that it's important with progesterone to go for prevention and not to wait for symptoms or for the hours just before the real onset of labor, because it will be too late to intervene. And in this perspective, the way to measure the cervix as soon as possible makes sense, because earlier you will know that there is a shortening of the cervix, better you will be active administrating progesterone. So we have to be very prudent and cautious comparing all the available progesterone. You know that progesterone is part of a family which is named progestagenes, and you have mainly three compounds. The natural one, which is the natural progesterone, or the 7-hydroxyprogesterone. But at least in the US, we use a lot of synthetic progestagene, and the main one in prevention of preterm birth, which is approved by the FDA, is the 7-hydroxyprogesterone caproate, but with a synthetic one. And just to keep in mind that those compounds are not exactly the same. And again, when you look at the efficiency of progesterone comparing to 7-hydroxyprogesterone caproate, this study by Bunzri in the American Journal 2005 was showing nicely that the natural progesterone reduces the myometrial oxytocin-induced contraction immediately, but at the same time 7-hydroxyprogesterone doesn't inhibit the uterine contractility. So you have to be very careful comparing progesterone one and other, because again, in terms of biological activity, they are probably different. And that's not only based on biological plausibility, but if you look at face-to-face comparison, that was an elegant study by the group of Maher in the Acta Obstetrica Gynecology Scandinavia in 2013. They did a face-to-face comparison between vaginal progesterone and 7-hydroxyprogesterone in women with a history of a previous preterm birth, and as Yves mentioned, is a very strong risk factor to identify the woman at risk. And at least in this study, there was a higher probability of continuation of pregnancy at term gestation comparing to the synthetic intramuscular progesterone. It's just one study. It's very controversial, but I just want to show you that you have to be very cautious when you look at the clinical data about progesterone, having a look which progesterone it is, and also to look at the route of administration. We all know that for the time being, in the US at least, the only progesterone which is approved for the prevention of preterm birth is the Makena, which is a 7-hydroxyprogesterone caproate, and it's only in women with a history of a spontaneous singleton preterm birth. But I want to focus on a very recent publication 2 weeks ago by Nelson in 2017, who was confirming some preliminary data that we knew since 2007 by the group of Rebarber, and looking at the safety profile of those progestagene, and there is more and more evidence suggesting that synthetic progestagene, at least the caproate 7-hydroxy-P, can lead to an increased risk for gestational diabetes, and that's certainly not good news in terms of the safety profile of this progestagene. At the same time, we have also to take into consideration the patient compliance and acceptance, and we know that there are a lot of painful reaction, even swelling or nodules, and giving some concern about the patient compliance with the injection. And very recently also the group of Piette 2013 was showing that even the level of natural progesterone, the blood level, can interfere on the metabolism of the 7-hydroxyprogesterone caproate. So again, be very careful comparing progesterone with another. What about the route of administration? You know that there is a problem, probably a difference between synthetic and natural progesterone, but there is also a difference depending the route of administration. And as you can see, if you take progesterone by the oral route of administration, which is a very nice route of administration since progesterone was micronized in oil, making the natural progesterone bioavailable by oral route of administration. But you have to keep in mind that there is a huge first liver metabolism leading to the formation of metabolites, which are 5-alpha and 5-beta reduced metabolites. And those metabolites could be deleterious if they induce sleepiness or drowsiness and so on, but it can have a very nice positive effect in the pregnancy maintenance, knowing that those metabolites, allopregnanolone mainly, will fix the GABA receptor, and I will show you how it could be beneficial for the brain and for the fetal brain development. Intramuscular, we spoke about the 70-hydroxy-P and all the discomfort related to the painful injection, and that's probably the reason why in the clinical trial I will show you, most of the trial were done with vaginal progesterone because it delivers consistent systemic levels of progesterone. You avoid this first liver metabolism leading to high metabolites which can be deleterious in terms of adverse event. And you have two possibilities if you go for vaginal progesterone, or you use vaginal capsules of micronized progesterone, or in the US what they are suggesting is the vaginal gel, which is named Crinone. So, about the vaginal route of administration, we were showing more than 10 years ago that it makes sense. As I was mentioning that the cervix, and Eve was showing us nicely how important is the cervix, I think that it makes sense for sure to apply the progesterone at the vaginal level, and we have some scientific data showing that you have a real migration of the progesterone through the cervical tissue and the lower segment of the uterus up to the fundus. So you deliver an optimal level of progesterone at the cervix level, exactly where the progesterone is supposed to be active, and that's what we call the first uterine pass effect. I told you that the molecule is also important, and not only progesterone participate to the effect on the protection of the cervix, but also the metabolites, and you can see that even some metabolites of natural progesterone are even more efficacious in terms of inhibition of the contractility of the uterus. So that's the reason why all those clinical trials were done with vaginal progesterone, delivering a high local cervix level of progesterone, an optimal uterine concentration, a good bioavailability, very, very stable and high level of progesterone, and it's patient-friendly because you know from our IVF experience that since more than 30 years, millions of women are using progesterone vaginally for luteal phase support. I told you that probably the neuro effect of progesterone and the fact that progesterone binds the GABA receptor is of importance. And as you can see here, you have, based on this model, the suggestion that allopregnanolone, which is a metabolite of progesterone, modulates the GABA receptor, giving some protection at the fetal brain and against hypoxia and the risk of ischemia. And to convince you about this important effect, we have to know that there is an active biosynthetic pathway of progesterone at the brain level. So progesterone is not only produced by the ovaries, it's also produced in the brain, and you have the classical pathway of the synthesis of progesterone from cholesterol. But what's important in the brain will produce allopregnanolone, and this reaction is reversible. So from pregnanolone, it can go back to progesterone and produce all the beneficial effect at the brain level of your progesterone. And we know that it's going through the GABA receptor, and we know exactly where allopregnanolone is binding the GABA receptor, prolonging the opening of the chloride channel. But there is no only one pathway, and very recently the group of Brunton in 2014 was suggesting that allopregnanolone is also working through the opioid mechanism, which are involved in suppressing the hypothalamic-pituitary adrenal axis response in late pregnancy. So we know that progesterone works, but that's in animals model. What about clinical trials? And what I want to share with you is something very important coming from the Optimum trial. I will show you the trial in the next slide. But what I want to show you that in the primary outcomes of the Optimum trial, there were some measurements of brain injury by ultrasound scan in the neonates, and you can see that there was half of brain injuries in the fetus, in the children born from the mother taking vaginal progesterone, twice more brain injury in the placebo group comparing to the progesterone group, and it was highly statistically significant, and that's the reason why also the neonatal death was statistically different, 1% in the placebo group, but only 0.2% in the neonatal death, and they were part of the primary outcome of the Optimum trial. And in another independent study that we ran more than 10 years ago in Scandinavian countries, the PREIS study, that was a study about the effect of progesterone, vaginal progesterone in twins, we had a long-term follow-up on the neurophysiological development and the hospital admission in the twins. And now we have a follow-up after 8 years of age. And you can see that there was also, based on age stage questionnaire, there was a statistically significant improvement in the neurobrain function in the twins which were born from mother taking vaginal progesterone. So you have two now independent studies going in the same direction. And again, we have nice biological support for that. We know from this elegant study from the group of Paris, published 2012 in endocrinology, that if you do an occlusion of the middle cerebral artery in mice, and that you create this kind of experimental stroke, those mice will totally recover from their stroke if you are administrating progesterone, at the condition that those mice have progesterone receptors, and they will not recover if those knockout mice are progesterone knockout receptors. So showing that progesterone has a clear neuroprotective effect. So what about the clinical trials? Since now 2003, the first trial by Mace in the New England Journal, there are a lot of studies showing the efficacy of progesterone in the prevention of preterm birth. And just to keep it simple, and as it was mentioned by the previous speakers, in terms of strategy in the prevention, you have three possibilities. Or you can suggest progesterone, you have cerclage, or you have the arabine pessary, and in front of you, you have patients with clear identified risk factors, and the most common one are the prior history of a preterm birth, the twin pregnancies, and the short cervix. So if you look at the short cervix, it's probably the single most powerful predictor for the preterm delivery in the index pregnancy. And we have to look what's about the short cervix in three different situations. Women without no prior history of preterm birth, because as Eve was mentioning, that's a very strong factor also for a risk for preterm birth. What about short cervix in twins? And what about women with a history of a previous spontaneous preterm birth and a short cervix? So if we look at the woman just with a short cervix without symptoms, there was two studies which are level 1 of evidence, randomized placebo-controlled study. The first one, who was supported by the Fetal Medicine Foundation by Kypros Nicolaides and published by my friend Eduardo Fonseca in the New England 2007. And he was showing that you can decrease from 30% to 70% the rate of preterm birth before week 33 when the cervix was short. And it was really a short cervix, lesser than 15 millimeters. And as Eve was mentioning, the length and the cutoff length of the cervix is very important in terms of positive and negative predictive value for the risk of preterm birth. What the group of Romero and Sonia Hassan did in the US was to take another cutoff level in between 10 and 20 millimeters, and again, he received exactly and he observed the same results as for the Kypros study, and we see that the rate of preterm birth was a little bit smaller because the cutoff level was in between 10 and 20 millimeters. So, comparing with the Fonseca trial, who was only 15 millimeters. So the conclusion overall from those two randomized clinical trials were showing that you have a 45% reduction in the risk of preterm delivery and a significant decrease in neonatal morbidity and mortality in both studies. Then came the UK study, the Optimum trial by Jane Norman in the Lancet 2016, was a study was a little bit more difficult to understand because it was a pragmatic study, and the study was not including only women with a short cervix. So I have no time to spend about all the Optimum trial, but based on the comment by Roberto Romero, the trial was definitely underpowered to determine the effect of progesterone in the prevention of preterm birth in women at least with a short cervix. But you have to see the poor compliance in the Optimum trial. Lesser than 70% of the patients took their medication, placebo or progesterone. However, when you look at the primary outcomes, there was some statistical significance, not for the prevention of preterm birth per se, because it was an heterogeneous population mixing not only women with a short cervix, but also women with a history, women with some endometrial conization, and so on. So there was a very heterogeneous group of women, but unless there was 5 times less neonatal death in the progesterone group, 2 times less brain injury, as I mentioned, and based on the discussion in the study, it was suggested that we need to look at the results of Optimum in terms of subgroup, more especially women with a short cervix, and to see if, when we put it in a meta-analysis, we can get statistical significance. Because in the Optimum trial, as you can see, there was a clear trend of a decrease in the rate of preterm birth before week 34 in the progesterone group comparing with the placebo group in the same range as in the Fonseca trial and the Sonia Hassan publication. Interestingly, in the Optimum trial, when you look at the subgroup of women with a history of spontaneous preterm birth, you can see that in terms of neonatal outcome, which is one of the major endpoints that you look at when you want to prevent preterm birth, the neonatal outcome reached nearby the statistical significance level, P0053, and there was a 50% reduction in neonatal outcomes in the subgroup of women with a history of spontaneous preterm birth. So it is noteworthy that the Optimum trial was underpowered to detect a meaningful difference between vaginal progesterone and the placebo in the group of women with a short cervix. That's the reason why Roberto Romero published a meta-analysis combining all the results of the Hassan publication, the Fonseca trial, and the Optimum trial that I was mentioning in my previous slide. And the conclusion from Roberto Romero is very clear. Vaginal progesterone administration to asymptomatic women with a singleton gestation and a sonographic short cervix decreases the preterm birth before 34 weeks of gestation, the neonatal morbidity, and the mortality. So, in terms of intention to treat, as Yves was mentioning, is quite very impressive because you can see that you can save at least 1 preterm birth if you treat 11 pregnant women, singleton, and you can prevent 1 preterm birth before week 33. And in terms of respiratory distress syndrome, which is the major complication of preterm birth, you can see that you will save 1 respiratory distress syndrome in 18 patients to be treated, which is quite very more impressive than in comparing to the classical drugs that you are using in perinatal medicine, such as antenatal corticosteroid or magnesium sulfate. You can see that the number to treat are quite higher comparing with the progesterone effect. What about twins? Very interesting, because we knew since the publication of the individual patient data meta-analysis by Ben Willem Moll that there was an efficacy of progesterone suggested in women with a short cervix, in twins at least, but Ben Willem Moll was saying that we need additional clinical trial. But the vaginal progesterone was suggested to be effective in the reduction of adverse perinatal outcomes in women with a cervical length of less than 25 millimeters in twins. So it was interesting to look at a more recent meta-analysis who was published last week by the group of Roberto Romero again, who was looking this time at the twins population with a short cervix, incorporating the most recent study 2016 by El Refay. And as you can see, same kind of conclusion as in Singleton, and that's a new message, which is a very controversial issue. The administration of vaginal progesterone to asymptomatic women with a twin gestation and a sonographic short cervix in the mid-trimester reduces also the risk of preterm birth at 30 and until the preterm birth risk before 35 gestational weeks. But it's efficacious in decreasing neonatal mortality and some measure of neonatal morbidity. And that's probably the most important sentence from Roberto, without any demonstrable deleterious effects on childhood neurodevelopment, for the reason I was explaining. So I think that we have no time to go through the old controversial issue about cerclage, but at least in this indirect meta-analysis comparing cerclage and progesterone in a woman with a history of a previous preterm birth and a short cervix, there was no clear statistical difference between progesterone and cerclage, but as Yves mentioned, there are some elegant small studies suggesting that if you have a lot of previous preterm births, the association of progesterone of cerclage makes sense, and probably cerclage gives an additional efficacy in those risk women for preterm birth. But based on the indirect meta-analysis, the conclusion was that we have to look at the beneficial risk profile of each woman before taking a decision if you put a cerclage or if you are giving vaginal progesterone. If you look at the Cochrane review, the last one, the most recent one by Jody Dott, you can see that Jody Dott was showing nicely that progesterone, at least versus placebo, because Cochrane is only looking at to randomized controlled trial, placebo-controlled trial, you can see that progesterone was shown to be efficacious in short cervix, but also in women with a past history of spontaneous preterm birth, and it was preventing statistically significantly prevent preterm birth before week 34, 37, but it was also active on some neonatal outcomes, the stay in the neonatal intensive care units, and also on the birth weight of the infant. If you look at the guidelines, you have a recent FIGO recommendation recommending to do transvaginal sonography cervical length, as Yves was mentioning, and I think that everybody is now doing it, looking at all those recommendations, and that in a woman with a short cervix, the FIGO is recommending the vaginal progesterone capsules or the gel in the prevention of preterm birth, and that's in conformity with the other guidelines. You have here the guidelines for the SMFM in the US, and where Berghella was saying that there is a level 1 of evidence of prevention of preterm birth and non-natal benefits based on treating with vaginal progesterone low-risk singleton gestation identified with a transvaginal and not a transabdominal, as Yves was mentioning, a transvaginal screening to have a short cervix. And this strategy is not only beneficial in terms of outcomes, but it's also cost-effective, and it will be cost-saving. That was the same recommendation as by Yam in the New England Journal in 2014, Yam was the real first author who was focusing on the importance of the cervical length, and Yam was making a very strong statement in the New England recommending the use of progesterone in women with a previous preterm birth, short cervix, and that was objectivated in well-designed randomized clinical trials. In clinical practice, it's also important to see if our randomized controlled trial are according clinical practice are aligned, and you can see that in this very important tertiary hospital in the US, where they decide in 2010 or 2009 to change their policy and to give systematically progesterone in the prevention of preterm birth in the group of women I was mentioning in my last slide, you can see that the rate of preterm birth, not only before 37, but before 35 and 32 weeks of gestation age, was statistically significantly decreasing after 2010, when they decide to give systematically progesterone in those women. So to conclude, I can say that the role of progesterone in the physiopathology of pregnant women is crucial from conception until delivery, from conception, and certainly in IVF we know we have a lot of experience, until delivery for the prevention of preterm birth. There is a strong biological plausibility to support the exogenous progesterone in the management of prevention of preterm birth in women at risk. But the optimal dose, the route of administration and the duration remains to be determined if the women are symptomatic, because it's a more controversial issue. I told you, earlier, better. It's better to prevent than to treat. So in the pregnancy maintenance after tocolysis, we need more trial. But the neonatal effects in health infant and the cost effectiveness with vaginal micronized progesterone are now available, certainly with a level 1 of evidence in the woman with a short cervix. Thank you for your attention.